Glad to see you again in February. And this week, we are discussing the application and the safety of TMS in the treatment of epilepsy. And epilepsy is one of the most frequent neurological disorders characterized by recurrent, unprovoked seizures. And the pathophysiology of epilepsy is based on an imbalance between cortical inhibitory and excitatory circuits. Approximately a quarter of epilepsy patients do not experience adequate seizure control by antiepileptic drugs. And surgical intervention is a treatment option in certain patients suffering from medically intractable epilepsy, but it is not useful in some patients. Therefore, there remains a challenge in the management of these patients, and alternative therapeutic approaches needed to be developed. And rTMS is a non-invasive method used to modulate cortical excitability. And let's see the term in the detail. And these are our social media. You may also follow this social media to see more information about TMS. And first, we will have a brief definition of epilepsy. And as you can see, the task force proposed that epilepsy be considered to be a disease of the brain defined by any of the following conditions, including first, at least 2 unprovoked seizures occurring larger than 24 hours apart, and 2, 1 unprovoked seizure and a probability of further seizures similar to the general recurrence risk, at least 60% after 2 unprovoked seizures occurring over the next 10 years. Third, diagnosis of an epilepsy syndrome. And epilepsy resolved, and this resolve is not necessarily identical to the conventional view of remission or cure. Epilepsy is considered to be resolved for individuals who either had an age-dependent epilepsy syndrome but are now past the applicable age, or who have remained seizure-free for the last 10 years and off anti-seizure medicines for at least the last 5 years. This is the classification of seizure types expanded version in the 2017 ILAE, and the new classification does not represent a fundamental change but allows greater flexibility and transparency in naming seizure types. And the main editor, Dr. Fisher, said that correct treatment depends on knowing the exact type of seizure, and a more transparent classification system facilitates communication between teams, and more accurately communicates with patients and families. And the etiological diagnosis should be carried out throughout the patient's visit. And we will have a brief discussion about the pathogenesis of epilepsy, which is still unclear. And first, some studies suggest that the pathogenesis of epilepsy is related to the imbalance between excitatory and inhibitory neurotransmitters. And the ion channel theory holds that gene mutations alter the normal function of ion channel proteins, resulting in an imbalance of electrical activity in the central nervous system, inducing abnormal synchronous discharges and causing epileptic seizures. And some scholars believe the abnormal glial cell function is closely related to epileptic seizures, and abnormal astrocyte function can lead to disturbance of the glutamate and glutamine cycle, causing excessive excitation of neurons, thereby inducing epilepsy. And according to the theory of immune inflammatory factors, the immune response can lead to a decrease in the threshold of epileptic seizures, enhanced neuronal excitability, synaptic reconstruction, and damage to the blood-brain barrier, thereby causing epilepsy. And genetic factors may also lead to epileptic seizures by regulating ion channels, neuronal cell excitability, and so on. And epilepsy is one of the most common serious neurological disorders affecting about 39 million people as of 2015, and it affects 1% of the population by age 20 and 3% of the population by age 75. And it is more common in males than females, with the overall difference being small, but most of them with the disorder are in low-income populations or the developing world. At present, the treatment methods of epilepsy include drug therapy, surgery, ketogenic diet, and so on. And for drug therapy includes traditional and newer antiepileptic drugs, and surgical treatment is mainly aimed at some epilepsy patients who are ineffective in drug treatment. And ketogenic diet is one of the ways to treat drug-resistant epilepsy. And despite the development of new anti-epileptic drugs, about 1/3 of patients with epilepsy are still difficult to control with medication. And not all patients with epilepsy are candidates for surgery. And an increasing number of studies have shown that rTMS can reduce the frequency of seizures or reduce EEG epileptic form discharges, especially in patients with refractory epilepsy, with a significant reduction in the number of seizures treated with low-frequency rTMS. And now let's have a brief introduction with the mechanism of TMS. TMS uses a time-verifying pulse magnetic field to penetrate the scalp to form an induced electrical field in the brain's neuronal cells, and then generate induced currents to act on the nervous system, causing a series of physiological and biochemical changes, thereby affecting brain metabolism and neuronal excitability to improve the treatment and neurological diseases. And the principle is mainly based on the electromagnetic induction, and the whole process of TMS treatment is painless, non-invasive, which is also safe and effective. And as you can see in this part, I show several patterns of TMS, and these patterns have different functions and different effects. And current research suggests that rTMS may have multiple mechanisms for the treatment of epilepsy. First, different treatment frequencies will affect the glucose metabolism in the brain, and low-frequency stimulation can reduce the metabolic rate, while high-frequency stimulation can increase the metabolic rate. And rTMS works by reducing the metabolism in the epilepsy focus area, making it unable to maintain the energy required for epileptic seizures. And continuous regulation of cortical excitability by inducing long-term inhibition between synapses, thereby affecting the remodeling of cerebral cortex protrusions, enhancing inhibitory synapses and weakening excitatory synapses, thereby reducing the seizure period and abnormal discharges between episodes. And it can also reduce the release of stimulatory neurotransmitters and increase the release of inhibitory neurotransmitters, and achieve the effect of treating epilepsy through this two-way modulation. And TMS can also inhibit the overexpression of P-glycoprotein and reduce the doses of antiepileptic drugs. And central to the pathophysiology of epilepsy is a hyperexcitability of the cortex due to disturbances in the network of neurons in the brain. And rTMS pulses can be transmitted synaptically across neurons and affecting neurons downstream of the initially stimulated neuron. Thus, rTMS can both re-stimulate points and function in different brain networks. And low-frequency rTMS reduces cortical excitability in or near epileptic focus and modulates the function of neuronal networks in the brain, thereby affecting therapeutically. And we have mentioned the motor evoked potential, the MAP, before, and it is the muscle motor compound potential recorded in the contralateral target muscle by electrical and magnetic stimulation of the motor cortex of the brain. And MEP mainly reflects motor cortex excitability through cortical motor threshold and the cortical rest silence period and central motor conduction time, intracortical inhibition, and intracortical facilitation. And in this study, this is the demographic of participants included in each group. And for the results, all patients had significantly lower MTs, suggesting that cortical excitability is generally higher in epilepsy patients. And among them, patients with juvenile myoclonic epilepsy, which is JME, had lower MT than the other two types of patients, and which suggesting that JME, juvenile absence epilepsy, and generalized tonic-clonic epilepsy are different subtypes of epilepsy. And in patients, the application of TMS in studying the mechanism of antiepileptic drugs. And the LCM and CBZ are antiepileptic drugs, both acting on neuronal voltage-gated sodium channels. And TMS can describe drug reduces changes at the system level of the human cerebral cortex. And this study is designed to explore dose-dependent effects of LCM and effects of CBZ on motor cortex excitability with TMS in healthy human subjects. And subjects received 600 milligrams CBZ and 200 LCM and 400 LCM, or placebo preceding TMS measurements. And compared to placebo, TMS motor thresholds were significantly increased after CBZ and LCM, with a trend for dose-dependent effect of LCM. And both CBZ and LCM did not affect TMS parameters of intracortical synaptic excitability. And they have drawn the conclusion that TMS measurements suggest that LCM and CBZ predominantly act on neuronal membrane excitability. And in patients with unsatisfactory drug control of epilepsy, the MT value did not change significantly, and it is suspected that the MT value can be used to predict which drugs can effectively resist epilepsy and provide a new direction for drug selection. And the quality of pre-surgical evaluation in focal extratemporal epilepsy surgery is highly dependent on precise structural and functional identification of the epileptic focus, and navigated TMS can be a tool that combines the spatial information of high-resolution magnetic resonance image, which is the MRI, with the functionality of non-invasive cortical stimulation. And this suggests that it could be a promising tool for pre-surgical evaluation of cortical excitability. And pre-surgical navigated TMS evaluation was performed on an 8-year-old boy with who had left-sided intractable focal epilepsy, which also has somatosensory arousal in this study. And one singular MEP could be elicited in the unaffected hemisphere. And in contrast, in the affected hemisphere, MEPs could be elicited over a large area of the cortex, even after stimulation strength was reduced by at least 44%. And the latency stratification in the affected hemisphere differentiated a motor from a sensory region of interest, and stimulation over the sensory region induced a sensory arousal. And they had drawn a conclusion that non-invasive navigated TMS can locate pathological excitability with high spatial precision. And future studies should compare navigated TMS with direct cortex stimulation, as well as the combination of navigated TMS with EEG in a larger patient collective. So let's focus on how does TMS used in the treatment of epilepsy. This is the level of C of recommendation from the therapeutic guidelines for the use of rTMS, and they have recommended that rTMS has a possible anti-epileptic effect, which is to use a low-frequency rTMS of the epileptic focus. And low-frequency rTMS can reduce seizure, the number of seizures in patients with refractory epilepsy, and the curative effect is more significant in patients with neurocortical epilepsy and focal cortical dysplasia. And the anti-epileptic effect lasts for at least 2 to 4 weeks using a 1 to 2 week stimulation paradigm. And the curative effect of patients with mesotemporal lobe epilepsy is average. And in this study, they have included with 12 articles with 246 participants. And they have found that low-frequency rTMS treatment can reduce epileptic seizures. And patients aged under 21 years old using a figure of 8 coil and to simulate the temporal lobe, seizures are more likely to show good results than extratemporal seizures. And first, as you can see for the MRI images obtained at day 47 of care at the intensive care unit, and the right side of the brain to the left of the image. And above, T2 weighted image with increased signal intensity in temporal areas bilaterally with right-sided preponderance. Below, contrast-enhanced T1 weighted image with a sign of barrier disruption lateral to the anterior part of the right temporal horn. And the right figure shows the overall of clinical and the EEG parameters over the 50 days of intensive care treatment. And this study has investigated the effect of low-frequency rTMS guided by EEG on the super-refractory status and epilepticus unresponsive to conventional treatment for 44 days, including repeated deep sedation. rTMS was delivered for 1 hour sessions for 8 days. From the 3rd day of stimulation, the EEG pathology markedly decreased in parallel to clinical improvement. The patient could be weaned off the respirator, transferred to an ordinary ward, then to a rehabilitation clinic in the context of refractory partial status epilepticus. And neuromodulation through rTMS is a safe treatment option for these patients. And if performed along the lines herein described, it may also be more efficient than conventional treatment. And safety is one of the concerns to use TMS in patients with epilepsy. And despite being considered as safe technique, rTMS carries the risk of inducing seizures, among other minor adverse events. And thus, its safety in the population with epilepsy should be continuously assessed. And they have performed an updated systematic view on the safety of tolerability of rTMS in patients with epilepsy. And presence or absence of adverse events was reported in 40 studies with a number of 426 subjects. And a total of 78, which is about 18% of subjects, reported adverse events, and of which most of them were mild, and headache or dizziness was the most common one, occurring in about 9%, and they have found a crude per subject seizure risk of about 3%. And given that 12 subjects reported seizure out of 410 subjects included in this analysis, and only one of the reported seizures was considered atypical in terms of the clinical characteristics of the patient's baseline seizures. And as you can see, this is the distribution of mild adverse events according to frequency of stimulation, which is lower than 1 Hertz. And as you can see, there is more safety to use low-frequency rTMS. And here are the challenges of TMS in treating epilepsy. First, the curative effect is related to the selected epilepsy type and seizure frequency. And the optimal stimulation parameters remain to be further explored, and more large sample multi-center randomized control studies are still needed to provide further strong medical evidence. And the optimization of TMS for the treatment of epilepsy is also necessary. And first, we can improve the positioning technology, such as TMS combined with EEG can reflect cortical excitability and connectivity in real time. Select the site with more significant cortical activation on EEG after stimulation as a stimulation site, and use navigation system combined with MRI image to guide positioning. And the fiber tracking technology based on diffusion tensor imaging can review the direction of nerve fibers in vivo, which can point out the direction of for rTMS to treat epilepsy at the microscopic level. And at present, circular coils and figure-of-8 coils are more commonly used, and double-cone coils with better depths can also be used. And for the TBS, especially for the CTBS, which has an inflammatory effect, which mainly inhibits the cortex, its inhibitory effects of MEP can last for 16 minutes, which is more durable than traditional rTMS. And the stimulation intensity is lower and the duration is shorter. We will have an introduction to 2 cases, which is cited from Shenzhen People's Hospital, the Department of Neurology. And for the first one is a 22-year-old female patient with recurrent episodes of disturbance of consciousness for more than 2 years. And this patient has no special history, no obvious abnormality was found in physical examination of the nervous system, and no obvious abnormality was found in EEG. And through these scales of diagnosis of epilepsy with depression and anxiety symptoms, and the doctor used a low-frequency rTMS, which is about 0.5 Hertz, to stimulate the right DLPFC. And the patient's headache was better than before, and the sleep quality was significantly improved. And the re-examination for the Hamilton Anxiety Scale score remained unchanged. And the PSQI score has reduced to only 4, and the seizures are reduced by about half. And the second case is a 77-year-old male patient who has episodic memory impairment for more than 2 years, and he has no special history, and they have diagnosis of the clinical considers the temporal lobe epilepsy, and the doctor chose to use 1 Hertz low-frequency rTMS to stimulate the right DLPFC. And after the treatment, the patient's episodic memory impairment was reduced to once every few months during the 6 months follow-up. And studies have shown that the most serious adverse effects of rTMS in the treatment of epilepsy is seizures during treatment. So the safety and tolerability of rTMS treatment in epilepsy patients are particularly important. A systematic review of the safety of rTMS in patients with epilepsy shows that compared with patients without epilepsy, rTMS has no additional risk of inducing epilepsy, and patients with epilepsy treated with rTMS have not yet seen induced status epilepticus or life-threatening seizures report, and the overall benefit from rTMS outweighed the risk of seizures. This is a protocol cited from these two professors, and as you can see, they have all used a low-frequency rTMS, and the treatment must be carried out in accordance with the diagnosis of the doctor, and these protocols are only used for reference. And that's all for my content. Thank you for your listening.